issues have been before us in the past. You may ask, what is a healthcare issue doing in the Senate Regulated Industries Committee? I think you'll very quickly realize that the reason is because healthcare is one of the most highly regulated industries in our state, and I do say it's an industry. It's quite a big share of our state budget is spent on healthcare for our citizens, and this is kind of a statutory framework that we've used for a long, long time, the Certificate of Need process. Back in 2019, there were several bills in the state legislature that, both in the Senate and the House, that dealt with modifications, including even a proposal for the complete repeal of the Certificate of Need program. Those bills came through this committee, and most of these same committee members were here at that time. Senator Dolezal's new, my vice chairman, Senator Summers, is new, but most of us were here and dealt with these issues. They didn't make a whole lot of changes, but there have been some sort of nipping away over the years at some of these requirements. Last week, we had a relatively full hearing on Senate Bill 99, including testimony from the public, which is a new exception or exemption to the requirements for a certificate of need, was aimed at rural hospitals to lessen some of the barriers to rural hospitals to allow new healthcare providers to build hospitals in the rural areas of the state. We had pretty thorough testimony on that. Everybody that signed up at that time was heard. So I am not inviting too much new additional testimony on that specific bill, but since these issues blend together pretty much hand in hand with Senate Bill 162, if you have a specific interest in Senate Bill 99, which is the more finite of these two bills that deals directly with rural hospitals, exemptions from the CON requirement, let me know. We'll try to call you first to be heard here on those issues. Senate Bill 162 is Senator Chairman Watson's bill that is essentially a total revamp of Certificate of Need. It does not completely eliminate it, but it certainly broadens the exemptions and renames the Certificate of Need process a Special Healthcare Services License. You're going to see a lot of the same language in the current statute on CON as is included here in 162. You'll be happy that in this committee sub, it went from literally about 150 pages to 45 pages, so it's a much more condensed version. It incorporates in it Senate Bill 99. So it gives this new exemption for the rural hospitals, and it is has a few tweaks on the other Senate Bill 99, but greatly pares down the whole CON process, essentially repealing that and replacing it with a healthcare services license. A lot of the participants in the field, the interested parties to this process, have been working since we had that first hearing over a week ago now to try to reach a compromise, to find terms that all the parties can live with. I don't think this substitute pleases every party, but I think you're going to hear a lot of healthcare providers agree that this is a good advancement on the regulation of the healthcare services industry and is supported by many of the participants in that. I am planning to hear anybody that wants to be heard. We have about 10 or 12 speakers. I'm going to let Senator Dolezal first speak briefly on a change he's agreed to his version. I'm going to hear a few people that I know are from Butts County that have an interest in that one particular hospital that's been proposed down there. We heard testimony from Wellstar last week of their views on this bill and their opposition to it, and sort of gave us an indication of where the local communities, the hospital authority, and the boards of commissioners stood on it. We have in our folders, gentlemen and ladies, a stack of correspondence from various residents in the Butts County area expressing their support for Senate Bill 99. I'm not going to call 20 people to reiterate what we have there in those letters, but feel free to peruse those as we hear testimony here today. And then I'll have Chairman Watson present 162. We'll have people speak on that, and then I intend to allow any action on this bill the committee feels are appropriate today. With that, I'm going to turn it over to you, Senator Dolezal, if you would please see if there's anything you need to add about your Senate Bill 99 and discuss with us the proposed amendment. We have in our folders, committee members, 2 or 3 different proposed amendments that have been presented to me. One of them is to Senate Bill 99. The other 2 are to 162. So the floor is yours. Senator Dolezal, yes, sir.
Mr. Chairman, in light of the fact that we just got this bill and it's got quite a bit of length to it, can we hold a vote off on this today? Because I've got a meeting with the Japanese embassy at 6, and for me, that's one of those things. I don't know where the bill. I hadn't had a chance to read it. I've been trying to.
You've read 99 because we already had a hearing on it. We'll certainly take action on that today if it's the will of the committee, and we'll see what the will of the committee is on 162.
We kind of rushed.
We'll go quick as we can.
I'd cancel dinner if I were you.
Senator Dolezal. Floor is yours, Senator Dolezal.
Thank you, Mr. Chairman and members of the committee. We had a robust hearing on this bill a little bit over a week ago, as the chairman mentioned, so I'm not going to belabor any of the points I previously made. I do know there are a number of folks here, though, or at least some folks from Butts County that would like to speak. I think we should probably hear from them, Mr. Chairman. But as to the amendment, which you'll find in your folders, it's quite simple. It simply strikes lines 23 through 25, which we think makes the bill a little bit too restrictive. It strikes lines 23 through 25 and then renumbers the items following that speaks to who this new exclusion for certificate of need will apply to and what the requirements of the application will be. And with that, Mr. Chairman, I would just point members of the committee to the letters from the Butts County Chamber of Commerce, members of the Board of Commission and the Hospital Authority. I think we may even have some of those folks here today that wish to speak as well.
So your amendment eliminates the requirement that you be a hospital authority? Correct. In order to qualify for that exemption for a rural health care provider? Okay.
That's correct.
Any questions for Senator Dolezal on that?
This does not, I'm sorry, this does not require 2/3 vote. This is not.
That's correct.
This is.
This is not.
No.
Yes, that's correct.
Senator Ginn.
Thank you, Mr. Chairman. And I know our chairman knows of our friend Dr. Reddy. He's managed to somehow provide a lot of rural health care services all over northeast Georgia. I think he's got maybe 17 clinics. I don't know how many. He does every kind of thing outside of going to a hospital that you need to do. And for me, would he be eligible for, this? How would that work for? He has clinics where he sees people that need either urgent care or they got a sinus infection or whatever the case may be. Is that something that?
Well, first of all, the county would have to qualify as a rural county in the code, which is a county less than 50,000 people. And then this speaks only to acute care hospitals. But if he wants to open a hospital, he would
has to be a hospital. Can't be a medical. Can't be where you go in, you get stitches or sewn up or whatever.
That's correct.
Can't be anything like that. It's got to be a hospital.
All right. All right. With that, then I'm happy to call to testify here today Mr. Joe Brown, who is in a unique position that serves on the Butts County Hospital Authority as well as the Butts County Commission. Mr. Brown, if you will go to that podium over there. Thank you, sir. And what we'd like for you to do, this may be your first time here, is introduce yourself and tell what your organizations are and give your opinion as to the rural health care exemption here that's contained in Senate Bill 99 and is also contained in Senate Bill 162.
Thank you.
Thank you, Mr. Brown.
It is my first time here, and I'm an old country boy from Jackson. Been there 71 years, so I wear 3 hats today. Number one, a 71-year resident of Butts County. Been on the Board of Commissioners now for 8 years, starting my 9th term, and I'm on the Butts County Hospital Authority. So when I saw the hearing last week that you folks went through, I don't think the whole story was told. So I'd like to give a little history about Butts County and what's going on in our hospital, and then I'll be glad to answer any questions that you have. Butts County will soon be 200 years old. Our tax digest, and we're proud, just reached $1 billion with a B. 200 years to get there. Now, we've been blessed in the last 3 years to acquire development coming in at 16 and 75 that's going to have 20 million square feet of industrial space, and of that, probably 70% is already sold. There'll be 5,000 employees. The front and 16 will all be retail and commercial. Again, there'll be 5,000 jobs just for the industrial. It's a regional thing for us, and this is not just for Butts County, but it's a regional thing in the fact also that South Henry County, meaning Locust Grove and South McDonough, over the last 2 years have added about 2,500 new rooftops. The city of Jackson, over the same period of time, has added 680-something rooftops. So Butts County is in a unique situation right now in the fact that I don't know of any other county in the state of Georgia that can say that. Now, our hospital is 60 years old. We've tried it 3 or 4 different ways. We tried owning it. We went broke 2 or 3 times. Back in 2000 I can't remember the exact date, but Tenant came in and they leased it from us, and they helped us from closing the hospital. And then Wellstar acquired Tenant, and they're currently leasing our hospital until 2026. Now, we, as a hospital authority, have listened to Wellstar tell us that we probably don't need a hospital at this point. What we need is some medical office buildings and whatever. We've had another group to come in and say, yes, you need a hospital, you need it now. So what we did as a hospital authority is we hired a firm, and I think you have a copy of that letter of engagement, but it's Nelson and Mullins, and they're coming in to do the work for us. Instead of listening to Wellstar or the other side, we're going to get all of our data. We know more than likely what it's going to say, but we're going to do that, so we'll have something to hang our hat on. And there again, the county commission is 100% behind this. You have a resolution signed by Keith Douglas, who's our chairman, who was coming today, but he works with the Georgia Diagnostic Prison, and at the last minute he couldn't get away. And I apologize, I send his regrets. You also have, from last year, to where the Board of Commissioners, and I was the chairman then, signed it, and we sent to the governor supporting that House bill then. And then, of course, the Mullis thing that the hospital authority has done. So I'll be glad to answer any questions that any of you guys have, or ladies.
How big is your hospital there now? You're on the hospital authority.
I am.
How many beds and what type of condition? That's the one you said 60 years old?
Yes. Okay, the hospital we have is a 25-bed hospital. Now, it's classified as an acute care hospital. Now, the difference that I know, the difference in an acute care and others is an acute care means that you can treat people other than an emergency room. You can bring them into the hospital and you can treat them. Butts County has one doctor that has admitting privileges to that hospital. Now, in the testimony last week, they said there were 14,000 people that came to the hospital last year, 14,000. Now, our hospital is mainly for rehab patients, in-house, and outpatient physical therapy. I had a hip replacement about 8 months ago, and we have the greatest, without a doubt, we have the greatest physical therapy unit in the state of Georgia. I'll match it against anybody. So, but I think it's a little misleading in the fact that of the 14,000 people that came, probably 95% of them was there for rehab / outpatient physical therapy.
Do you have your surgery there?
No, we don't do surgery there.
No surgeries at all at the Sylvan Grove
No.
facility?
No. Had my surgery down in Columbus,
All right.
but I had my physical therapy there.
So as a member of the hospital authority, it is your mission to help provide health care to the citizens of Butts County there?
Absolutely. And you see, here's the other issue that we have. If you put yourself in our shoes for a few minutes and you look at 2026, which is not that far away, and with everything going on in Butts County, we can't wait until 2026 for somebody to tell us, well, I'm sorry, it's been good, but thank you very much. We want to control, our hospital authority and county commissioners wants to control our own destiny as to what's happening out there. And I think that it's very important for us to be able to do that.
Are you supportive of a new hospital in your county?
Yes, sir.
And do you think there's going to be enough demand for it from patients as you're describing this growth that you've experienced and anticipate?
I do, and here's why. North of us, Piedmont has a hospital in Henry County, Piedmont Henry. Right now, they're so overcrowded that when you show up there, you have anywhere from a 12 to a 20-hour wait, okay? With all of the growth in Henry County coming down to us, then just with that alone, but with the growth that we've got in Butts County, I feel like that, yes. And they've talked about a 100-bed hospital. We've also got some other people interested in maybe some mental health to go with this. And then on the other hand, we have a state prison there in Jackson, Georgia Diagnostic and Classification Prison. They have 1,750 inmates.
That's the
And-
one you don't want to go to from what we hear, right?
Well, that's correct.
Electric chair lifts or
Well,
gas
yeah.
chamber now, whatever it is.
So they spend millions of dollars transporting patients from, and Mr. Douglas, who is an employee out there, he's a unit supervisor, he and I have been in communication a lot about, okay, if we had a hospital, how could we help the diagnostic prison? It's only 4 miles from where the hospital will be located from where the prison is. And when you transport a prisoner, you have to take security and you have to have all of that, which means extra people. It's something that we should explore is when we build this hospital, we put 10 beds or 20 beds that's dedicated to the state prison system, to where the security and all of that will be. I mean, all of this is just falling right into place for Butts County and the surrounding area. This is not just Butts County. This is a regional deal, and we're just proud to be there.
All right. Any other committee members have questions? Yes, sir. Senator Chairman Brass.
Thank you, Mr. Chairman. Sir, you had touched on the mental health a little bit, but I was reading here in the notes that this mental health provider y'all were in contact with, that they're expressing
A huge
interest
interest, yes.
and it's based on there being a new facility. Am I reading this right?
Well, I'll let Mr. Whitehouse address that a little further, but
Okay.
the other thing about this is I've been in every meeting between Wellstar and the developer, Wellstar and the county. So this has been going on for 2 years. And the mental health unit, there's 2 or 3 ways that you can do that. Talking about, we don't want to do anything to hurt Wellstar. This outfit would come in, and if they don't get to the new hospital, they've shown some interest in taking on 40 or 50 beds in Griffin. So we still work together, whether Wellstar is doing our hospital or whoever. We're all in this together, and we want to do what's best for all of our people.
Okay, thank you.
All right. Thank you. I appreciate you being here, Mr. Brown. Anybody else from Middle Georgia would like to be heard on the issue, any the communities directly affected? All right, then I'm going to turn it over at this point to Senator Ben Watson to present SB 162. Senator Watson, I think you've expressed an interest in just sitting here at the witness table. You don't have to go to the podium if you don't want to. You're live there at the center mic.
Thank you, Mr. Chair. I appreciate that. You know, Senate Bill 162, as the chairman alluded to, did start out over 100 pages and is now down to, I think, 45 pages. Let's talk about the bill itself a little bit, and then I want to bring up another topic that I think plays directly related to this. Yes, this does do away with CON and creates, as the chairman related, a special health care service license. So that's what this bill does basically. If you look at on page 2, these are the definitions. The definitions are unchanged and are applied in present law. And if you look at on line 144, that's a multi-specialty ambulatory surgery center. This has been used prior also. Not in present law, but is in past bills and concerning continuity and discussion. That's what is being used today. Goes into effect January 1, 2024, if passed by this body and the House, and then and signed by the governor. If we're looking at page 10 is basically where this starts after the definitions. And the special health care services license, if you see down there at the bottom, shall be required for the construction of new health care facility. And then it discusses the increase in by 10 beds, or as in like in Butts County, or 20% of bed capacity, whichever is greater. Then it discusses the conversion on line 245, the conversion of single specialty ambulatory surgery centers to multi-specialty. And the discussion there is relating to there are over 200 single specialty ambulatory surgery centers, and I will tell you, many of them are struggling from that perspective because they're not able to maintain full-time employees. They may be open 3 days a week, and they would easily converge and work together, i.e. maybe dentistry and a ENT practice, or orthopedics and urology, or some other specialty like that that could put their ambulatory surgery center together. And then it discusses the percentages. Let me digress a little bit. The first bill, the one that was over 100 pages, did away with CON completely. And that bill was maybe a little bit overreaching at this time, but in working with hospitals, both urban and rural and middle-sized, so to speak, hospitals, we have narrowed this down. And thus, many of these percentages and so forth are ones that we have worked with and have enjoyed that process. So in line 252, the special health care services license shall not...
Before you get to there, can I just make sure I'm following? The ones that you just described to construct a new hospital, do a replacement one, or do these conversions that you were just dealing, those currently require a certificate of need?
That is absolutely true.
And under your bill now, they will also require approval. You're just calling it a healthcare license?
That is correct.
And who is it that issues these either certificates of need or your healthcare services license?
At present, that is unchanged in this bill.
Okay, it's Department of Community Health now?
It is Department of Community Health. It is the commissioner.
Still will be in your new schematic here.
That's correct.
Okay. All right, so that's really not a change. You're just keeping current law the way it is, naming it a health services license rather than a certificate of need.
Correct.
Just so beginning at 252, is this where you make changes or exemptions from current requirements for permission to build these type facilities?
That's correct.
Let us
Thank you.
know how you change it then.
So the new exemptions, and basically using Senator Chairman Dolezal's SB 99, that starts on line 254 through 280, and that's that whole section there relating to that. And as with Dr. Dolezal, as with Chairman Dolezal, we do have the. I'm sorry for usurping that, Chairman. We do have the minor change relating to the definition. So that is those are the addition there. So that's from 254 to 280 is Senate Bill 99. So taking us through 280.
Let me interrupt you one more second then.
Yes.
You heard Dolezal's proposed amendment that eliminated the requirement that you be run by a county or municipal authority. Are you okay with that same change in yours to keep these consistent?
Yes.
Okay, I think that there's an amendment that's been drafted. It's in our folders that would make that change. Just want to make sure you're okay with that on your bill.
Yes.
All right, so now continue.
Thank you. So on line 281, all of those 281 through 493 is in current law. So lines 281 to 493 in current law with minor changes, basically relating to the health services license. And let me go through a couple here that may not be.
By saying they're in current law, you mean they are now exempt from the requirement of a CON today?
That's correct.
And
So
you're just
over the
making
years,
sure
the
they
exemptions
remain.
have been added and adjusted and so forth, and that's what's in present law now relating to CON. So this would, instead of being under CON, it would be under the hospital
Gotcha.
licensure. Sorry, thank you for doing that. On line 483, that was part of the change there with the capital expenditure. In other words, if someone wants to spend more than $10 million to build a facility, then certainly we didn't want to discourage that by any means as their campus. So that was removed from the old language, and that's in line 483.
So there's a friendly amendment then being proposed to eliminate this $10 million cap.
That's accurate.
So if you want to do a capital expenditure, you could spend $11 million or $111 million without having to get a special healthcare license.
Listen, if you want to make it the best hospital in the world, then that's on you.
All right, thank you. That amendment's also in your folders, committee members.
We added on line 529 about a facility that's located, 528 is located within a 35-mile radius. Those are the ones that can write a written objection, just as you do in CON, but with that adjustment. And so, in other words, is someone not in your catchment area. And in line 529, if you have closed a healthcare facility, then obviously if you've closed one and someone else wants to build one, then I don't think you have much of an argument there from that perspective. We kept in language in 542 about clear and convincing, not a change there. And then we defined, so it is interesting, and that's sort of what I wanted to talk about a little bit more. The scenario in the state of Georgia is that they're basically through consulting with the hospitals who brought this, specifically Grady and the Medical College of Georgia, and then the 21 research hospitals, and then the 61 rural hospitals. That's what's called the directed payment plan. So basically this shifts hospitals now to a position of having no uncompensated care. When I mean no uncompensated care, I mean no insurance when you walk in the door, or you have insurance that may not cover you in a very adequate fashion, i.e. Medicaid, which pays about, depending on which study you believe, 45 to 85% of the actual cost of the hospital. When I say cost, I don't mean $20 for a Tylenol. I mean what's accepted by CMS, Centers for Medicaid and Medicare federally definition of what the actual cost to the hospital. So let's take you through the directed payment plan. Let me help you understand that. And I will tell you, I still don't completely understand it. I've heard Commissioner Noggle present this at least 2 times, and I've helped her with the presentation, and I still don't 100% understand it, but I think I do have the big picture. The big picture is that about 14, 15 years ago, we did what's called the disproportionate share, or what's called the Indigent Care Trust Fund. And that's where hospitals, what they termed as bed taxes. And they drew down money from CMS that was matched in a very favorable way, to the point that that money was redistributed to hospitals that did do a disproportionate share of indigent care, i.e. no insurance or limited insurance like Medicaid, or we're paying out of pocket, so to speak. That money was distributed from the wealthy hospitals, so to speak, to the hospitals that were doing the lion's share of the indigent care. Those 2 hospitals that did most of the indigent care in the state of Georgia, or down the street at Grady and in Augusta. What used to be, when I was there, was Talmadge, or MCG, and what's been more recently called Augusta University, which I think may be going back to MCG, but that's neither here nor there. That's sort of left up to other entities besides me. So with the directed payment plan, no state money is used. It is another drawdown. Interestingly, the hospitals lobbied against the previous quote-unquote bed tax, but you've heard nothing about it this time from any hospital about being an issue. And here's why. Because when that money is brought down, and the 2 hospitals, Grady and Talmadge, or MCG or AU, are made whole completely, because their welfare patients, the Medicaid patients, are paid at a rate above commercial insurance, which is about $125 for commercial. Medicare, meaning that's about 130% that they're getting paid. So MCG and Grady were made whole completely with no uncompensated care back in November and December. This has been worked on for about 2.5 years. It began in Arizona, moved to about a dozen other states, including Texas, and we used the Kentucky model. So that is a going forward payment plan. It's paid retrospectively, not prospectively, meaning that you don't pay it when the patient enters a hospital. You pay it after they leave, and you base that on your actual cost that CMS determines. To the point that when Grady received this payment, they were not able to receive, or they had reached their upper limits on this. And I will tell you, all the terms sort of flow together at times, so I'm not using the exact terms, but they had maxed out on what they had gotten. They had to give back $105 million because they had reached their max. Also with this payment plan, the 21 teaching hospitals, i.e., those hospitals like where I live at Memorial in Savannah that has a residency program, multiple residency programs, Wellstar, which has a multiple residency programs, and has now even more with closing of the Atlanta Medical Center, which you got to remember was a level 1 trauma care place, and level 1 trauma centers have residencies in surgery, medicine, neurology. They got a neurosurgeon on call. They are covered to the max. They did not lose those residencies. And then other hospitals like in Columbus, Macon, Savannah, where I live, Albany, 21 different hospitals are also made whole. And they're made whole by their Medicaid patients too, which are paid just below or even with commercial pay. So all the uncompensated care for all 21 teaching hospitals and all of the 2 major teaching hospitals, there is no uncompensated care going forward as long as they meet parameters. Now the parameters that the 10% withhold that they do at the end relating to Grady and I'm going to use the word Talmadge or MCG. Those 2 hospitals have a 10% withhold that they have to meet quality metrics. Well, they don't get that 10%. Interestingly, guess who gets to set those quality metrics? Well, it's those hospitals. They get to set their own quality metrics. So Lo and behold, if you don't meet your own quality metrics, shame on you. The other hospitals, and I'll get to the rural hospitals in just a minute, have a 20% withhold, and that is for workforce. You know, before I came to Atlanta this session, what was the major term that we all used? We need to work on workforce. Well, this is something that is very tangible. 20% withhold on that. They have to work on their workforce, i.e. nurses, everybody who works in the hospital. They're the what considered providers there, and they also have to set their own parameters too when it comes to workforce. So shame on you if you don't set the workforce there appropriately. So then the rural hospitals, 61 rural hospitals, and Chairman Dolezal gave you the definition. A county less than 50,000. A hospital less than 100 beds. So all 61 hospitals redistributed the $105 million from Grady and also got some of the other aspects relating to the directed payment plan. They are also made whole. I think except maybe one was about 15,000 short, but I think they'll be made whole too. So all 61 rural hospitals have been made whole also. So that's interesting. So, and that's why. Now, I'll tell you my prediction, because all these ambulatory surgery centers and other CON facilities are required to do indigent care. Well, dang, all the indigent care in the state of Georgia basically is gone. It looks like it's going to be the ones who are asking for these health services that are going to be doing the indigent care, because they are not included in that formula. So that's what the rest of the section does relating to that. Thank you, Mr. Chairman.
So you're basically saying all the problems that we've been faced with for the last 2 decades, the rural hospitals closing and losing money, nobody's going to lose money anymore because they're going to get paid for every single patient they see at a rate that's higher than what they've been receiving for Medicaid?
And so basically what that does is that takes care of the Medicaid patients, and it takes care of all the ones who do not have insurance. Now, I didn't mention that our Medicaid waivers, the ACA waivers, are kicking in also about this time. And I also didn't mention that there are some for-profit hospitals throughout the state, not many, and they all pay property taxes. I'll give you an example. In my area in Savannah, one of the hospitals there pays about $9 million. And Savannah's about the size of Columbus or about the size of Macon. That hospital pays $9 million to the county and the city, and guess what that goes for? That goes for indigent care, but there's probably not going to be much indigent care now. But that's going to be put on your tax rolls if you were a not-for-profit. And that also, for-profit hospital, by the way, also pays corporate taxes. So you have not-for-profits that also get supported by not paying property taxes and not paying corporate taxes. And in rural hospitals, we pass the rural hospital tax credit. And I know that Senator Albers, Chairman Albers, is always looking at tax credits. I'm not asking him to look at this tax credit, but, you know, listen, all rural hospitals in the state of Georgia, 61 rural hospitals now are not going to be short on cash.
Senator Ginn has a question for you, then we're going to let some speakers share their thoughts. Senator Ginn, you're recognized.
Thank you, Mr. Chairman. I was curious on the not-for-profit versus the profit hospitals. What's the percentage on that across the state?
It's a real, I don't know the numbers. It's a small percentage. I can't give you the number.
Most all the ones I know are not-for-profit.
They are.
Okay. I didn't think there were very many for-profit hospitals.
I'm going to let my vice chairman ask you one question, then we'll hear speakers.
Chairman Watson, what rural hospitals have you spoke with about this, and what's been their response? When I say rural, I mean, I'm rural.
Yeah, I mean, the rural hospitals, I will tell you the communication has not been as good as I had hoped. There's not been a lot of transparency and straightforwardness. you know, I start off many of my meetings, if we do what's right for the patient, then we'll do what's right, do the right thing from that perspective. And I also say that, you know, ignorance is curable, stupidity is not. So listen, Commissioner Noggle has spoken to every CFO, has offered, she's done phone conferences with the CFOs of each one of these hospitals. They know the money's there, they know the money's coming. I hope the big concern, I will tell you, when we were doing appropriations mostly was that with this windfall, and yes, there's going to be significant money there because obviously they've been getting along without it before, except for all the benefits that they do get, i.e. the tax credit and the not-for-profit not paying property taxes or corporate taxes. There's going to be significant money there, and you hope that everybody manages it appropriately. You know, will they get the 20% when it comes to the workforce holdback? You would hope so. So I think there's going to need to be education. I know that DCH has been working with that, i.e. DCH is the one that handles Medicaid.
Senator Dolezal, I'm trying to limit these. Go
Well,
ahead.
I
Since you
can-
have a
I-
bill pending,
I can wait, Mr. Chairman, until I just had a
Go
quick
ahead.
question. I want to make sure I understand what you just told us. I think that what you just told us is that if I'm uninsured and you're insured, and we both walk into an emergency room, while the hospital is being compelled by law to provide care to both of us, the hospital ultimately then is being compensated essentially equally for both of us.
Right, not on the front end, but on the back end. The hospital is. Now, not necessarily the physicians or the other healthcare providers, but the hospital will be made whole.
So the traditional argument that I've heard against repealing or changing certificate of need is we, the hospitals, you're forcing us to provide all this indigent care. You're forcing us to provide the non-profitable side of the business. Don't allow anybody else to open up across the street because they're just going to open up with the profitable side of the business, take away the profitable side of the business. But it sounds to me like this changes everything, if what I'm hearing you say correctly. This changes everything relative to that argument because the economics of the hospital business have fundamentally changed.
I think that's accurate, yes.
Senator Lucas, don't want to leave the minority party out.
It ain't about the minority party, it's about the money. My understanding, Senator, is uncompensated care. Now, CMS has a rule, a 35-mile rule, that basically keeps so-called hospitals with billing in the 35-mile radius in order to be compensated with Medicaid and Medicare. Because they are the ones who dictate the Medicaid and Medicare. If that is true, how do we have 500,000 Georgians who can't afford no insurance and get to the hospitals, and the hospitals got to take care of uncompensated pay? Where do they get the money at the end of the year then?
So that, again, listen, let me tell you, Senator Lucas, I had to hear this thing several times to understand it. It's not an easy concept. So the hospitals draw down money from CMS, and it's about a 3-to-1 match, if I remember correctly, the numbers. And it is done on the back end. It's not done when you walk in the door. They're getting compensated. It's done, they, so to speak, settle up at the end of the year, for lack of a better term. And that's the way they get done. So they draw down that money as a match. And the way they do that is based on your Medicaid, how many Medicaid patients, because they calculate the Medicaid patients. And remember, that doesn't generally pay somewhere, maybe if it's 50% or 85%, depending on how you calculate that. But for real dollars, they will be reimbursing those hospitals at, again, MCG and Grady above commercial rates, 21 teaching hospitals just below, if not equal to, commercial rates. Did that help you understand?
Well, then what you're telling me, while we've been talking about Medicaid expansion, we don't need Medicaid expansion. In other words, folks.
Well, you got to remember that this is for providers, and they define providers, Medicare, of hospitals, which hospitals are really facilities. I guess they are providers, but it's not really as a physician, up until just a few months ago, I was going to the hospital and seeing my patients there. And over the decades, I have taken call at the hospital in the emergency room and see patients that don't have insurance or may have insurance. Many of them that would come in would not. So, no, as a physician, I would not get compensated. But the hospital facility does get compensated.
So how do you get paid?
How do I get paid?
Yeah, I mean, you ain't doing it free.
Well,
Check his salary out.
yeah, as
He's not getting paid while he's testifying for us other than his $170 per diem, so let's move on. Ann Adams, please come to the podium and let us know your views on behalf of Georgia Hospital Association.
Thank you, Mr. Chairman, members of the committee. It's good to be before you again today. I'm Anna Adams with the Georgia Hospital Association. Again, we represent about 150 hospitals statewide, and we at GHA do enjoy a very diverse membership. We have small rural hospitals, psychiatric facilities, acute care hospitals that are standalone, member hospitals that are system facilities. So as we are looking at Senate Bill 162, I will tell you that as it was introduced, we did have some significant concerns and challenges with the bill. I'll say that even as it is currently written, this is a pretty sweeping fundamental change to the way that healthcare is offered in the state of Georgia, not just for hospitals, but for other facilities as well. And so we would appreciate more time to be able to look at this on a facility level basis. And I would encourage each of you to reach out to your local hospitals too, because I think the impact of this is going to be different for rural facilities, for larger facilities, for psychiatric facilities, et cetera. So it's not just a one-size-fits-all CON approach. I'll say that we have been at the table and continue to want to be at the table. I think I testified before you last week to say that we have some recommendations for what could make this a little bit better. This bill is different for us from 99. We were close to getting to a position of neutral on 99. Unfortunately, we've not been able to see a lot of changes to that bill, but we still, again, want to have that conversation and think we could get there. This one is a little bit more problematic for us. So, again, we would like to have that conversation. We would like for our members to weigh in with us specifically to let us know what this bill means for them before we can feel comfortable moving forward.
Thank you very much. Mr. Thomas Worthy from Piedmont Healthcare.
Good afternoon, Mr. Chairman, members of the committee. My name's Thomas Worthy. I'm Vice President of External Affairs for Piedmont Healthcare. Piedmont is Georgia's largest not-for-profit health system. We operate 22 hospitals serving 3.4 million patients with 5,900 physicians and 37,500 employees. Our service area includes 80% of the state's population. 11 of the 13 of you have a Piedmont facility in your district. All 13 of you have constituents that are Piedmont patients and employees. This is my sixth session with Piedmont. I feel like CON is an exercise that we go through almost every 3 years. I think the goal of this hearing, and I think the goal of SB 162 is to level set on the Certificate of Need, an exercise that we seem to do frequently. However, Piedmont believes that this ongoing discussion is strangling us all. It's keeping us from discussing really important things like violence against healthcare workers, network stability, adequate reimbursement for hospitals, increasing healthcare coverage, and the ever-important mental health. As you hear from proponents and opponents of this legislation, you'll probably get hit with a lot of studies. I did what they taught me to do in law school and found a peer-reviewed law review about CON. I'm not going to read it all, but I think it's really important, this paragraph. It says, whether or not a federal mandate of CON continues, it appears that substantial numbers of states will retain Certificate of Need programs since CON regulation continues to satisfy a wide range of important state policy roles. However, it also appears that several states may abandon the program in the absence of federal requirements to retain it in favor of efforts to promote a more competitive health service markets. This might well be a fortuitous development, like any other regulatory program that intervenes in the market to accomplish social good. The need for CON programs ought to be continuously evaluated and the scope of the program tailored to meet specific, concrete, and current purposes. This is difficult to do when all states adopt a nationally mandated program. The repeal of the program in some jurisdictions would offer opportunities to measure the impact of the presence or absence of CON on the direction and scope of healthcare expenditures. That sounds applicable today. That article was from July of 1985. I was 3 years old.
Is there a federal CON?
I wanted to make sure to throw in my youth there. But the article is correct. There are compelling, legitimate, important government interests in state health planning regulatory frameworks. The calls for free market competition don't appreciate the fact that it doesn't really work in healthcare, and they conveniently ignore that where full repeal has failed miserably, such as in Texas. However, there are also very compelling and substantive calls for repeal. Forbes magazine, the Obama administration, FTC, the Trump administration, FTC, Americans for Prosperity, Georgia Public Policy Foundation, et cetera, et cetera, et cetera. Except as that 1985 article suggests, it's all about balance. To be clear, Piedmont strongly and unapologetically believes that the state plays an important role in health planning that guarantees consistency, knowing health gaps among the most vulnerable Georgians that the industry and the free market are not capable of identifying, and more importantly, guaranteeing bonds and other local financing that are so important for many of our hospitals. And a full repeal does not guarantee a reduction in healthcare costs. For example, at Piedmont, by maximizing our economies and efficiencies of scale and cutting duplication of waste, and putting the patient at the center of every business decision we make. Before COVID upset our business operations, we actually reduced the per patient cost by 3% between 2016 and 2019, while costs in every other industry were skyrocketing. But we also believe that much of the Georgia CON law as it exists today is antiquated, burdensome, and at times is used to hinder innovation. So, as the article states, as we believe, CON programs ought to be continuously evaluated, and the scope of the program ought to be tailored to meet specific, concrete, and current purposes. SB 162, in our opinion, is an attempt to do just that. It maintains an important role that the state plays while aggressively eliminating burdensome regulation that is often used in anti-competitive behaviors. To be completely transparent with the committee, we did not receive the sub until 2 o'clock this afternoon. As Ms. Adams stated, it is a lot to digest. But we're deeply appreciative of the collaboration that we've seen from the sponsor, from this committee's leadership, all of the Senate leadership, and the LG's office. So we believe that this version of 162 is something that we could possibly support with the understanding that if we identify concerns after a full review and they're addressed and negotiated in good faith without emotion, we trust that that will occur. So thank you for your time and consideration, and I'll be happy to answer any questions.
Thank you. Ryan Loke from Grady Healthcare. We're going to circle back questions after everybody gets to talk. I've got 8 more speakers.
Thank you, Mr. Chairman, members of the committee. I'm Ryan Loke. I'm Senior Vice President, Chief Health Policy Officer at Grady Health System. Not going to echo a lot of what Thomas has already stated for you guys, but for the record, I was not alive in 1985, so I can't speak to that portion of his comments. We at Grady support the intent of what the committee and the author are trying to accomplish here. Prior to coming to Grady, I was the Deputy Commissioner of the Department of Community Health, and for the 11 months that I was there, probably every other phone call I got was about CON and the CON process. So I've got a unique perspective on what you guys are trying to reckon with right now. So I think to kind of put a finer point on what Thomas said, we just got this bill about 3 hours ago. We respect the intent of where you guys are trying to go and the position that the committee is headed towards. We look forward to working with Chairman Watson and others to put this discussion around CON behind us. I think Thomas said it eloquently. We've done this every 3 years for what feels like an eternity now. We look forward to working with you guys to put some more pressing issues that affect the healthcare of Georgians front and center. I appreciate Chairman Watson bringing up the directed payment program. I was a part of the team that got to help design that at DCH. And if you haven't had the chance to sit down one-on-one with Commissioner Noggle and walk through that, it's a pretty incredible program, about $1 billion net new to the state's hospitals every single year as a result. And just lastly, at Grady, as Atlanta's only level 1 trauma center, we remain committed to serving all the patients in the communities that we serve, and thank the committee for the opportunity to speak to him. Happy to answer any questions.
Do you support Senate Bill 99? You've had that for several weeks now.
Yes, sir. Senate Bill 99 doesn't impact us. We just have the one hospital half mile down the street, so I don't think we'd have a position on it.
All right. Thank you.
Yes, sir.
Jesse Wethington.
Thank you, Mr. Chairman, members of the committee. My name is Jesse Wethington. I'm the president of the Georgia Association of Health Plans, which is the industry group for the state's health benefits and insurance industry. We're very much in support of Senate Bill 162. I'd like to applaud Senator Watson for bringing this very much needed measure to before you all today. It's well past time to address the harms that have been caused by Georgia's Byzantine and antiquated market distorting regulation known as Certificate of Need. Why is that? We typically look at healthcare policy impacts across, that's impact on cost of care, quality of care, access to care. CON has a perverse effect of increasing costs by creating scarcity and creating local monopolies which take full advantage of their market power to aggressively increase prices. It reduces access by creating scarcity. You'll see that underserved communities will continue to remain underserved, and that if rural hospitals close under CON, despite its sort of purported ability to protect hospitals from closing, they are still closing, but it does still represent a barrier to a replacement facility being put into a community where there is a gap in care. And CON doesn't have a demonstrated impact on quality, good or bad. There's mixed evidence on this, but what it does do is decrease the valuable stock of capital equipment by capital expenditure thresholds or physical plant that's outdated because it hasn't been able to be replaced or repaired in a timely fashion. Our association is a member of the Coalition for CON Modernization, so we're in favor generally of any kind of diminution or increased competition, which SB 162 represents. The big piece of this for health insurers is the hospital landscape. So 2020 was kind of a landscape year, watershed year rather, and we've seen a couple of things that have been trends that are celebrated by the pandemic that continue. So in that year, more than half of the physicians in the state became employed by a hospital system or by a large group practice. And in 2021, of Georgia's 129 acute care hospitals, 40 of those are independent, 89 are in a system of one or more, and 30 are critical access hospitals. Of those 129 hospitals, that's 19,841 beds. 92% of those beds are in a system, and the 5 largest systems control 51% of the beds, or rather 30% of the hospitals control 51% of the beds on the state. What does that have on their ability to do business and thrive? According to the National Academy of State Health Policy, again in their hospital cost tool from 2021, no matter how you slice it by bed size, large, medium, small, very large, Georgia's hospitals on a net patient revenue basis are more profitable than the national average. One reason for that is that since 2011, the cost to charge ratio in aggregate for the entire industry has increased dramatically. So in 2011, it was about 3 times. The charge amount was 3x what the hospital's cost level was. By 2021, that had increased to almost 8 times. And so the consolidation that you have seen happen over the last 10 to 12 years is really starting to show in their ability to price aggressively, particularly in markets where there are not competition. So we would ask for some relief on that, particularly in the metropolitan Atlanta market, which is really where the cost drivers in the big systems are. There are some accommodations for rural Georgia in Senate Bill 162. We feel those are reasonable. I'll close briefly by saying that CON is an outdated law that locks in the health planning economy logic of the 1970s. It was sold as a cost containment measure. It's failed on that metric, but what it amounts to today is a little more than a protectionist barrier to entry for incumbent providers. Can't emphasize enough Senator Watson's mention of the directed payment programs, that bringing up to a parity for payment for uninsured or underinsured patients really is transformative for the landscape, and it takes away the argument that the cross-subsidization ability has to be there, as Senator Dolezal pointed out. And lastly, what I would suggest to you is that what the state needs more than anything is increased competition in our healthcare market. We constantly hear about workforce issues, shortages, and lack of providers. As health insurers, we need more people to contract with. Additional competition would allow us to do that, to have more robust networks and more affordable care for your citizens across the state. Thank you.
Thank you. Sidney Wilkins with Emory Healthcare.
Good afternoon, everyone. I am Sydney Wilkins, and I am the Director of State Affairs at Emory. Thank you to the committee members, Chairman Cowsert and Chairman Watson, for welcoming discussion on this bill. Emory Healthcare is interested in engaging with the committee on finding solutions to improving access, reducing cost, and supporting the overall financial stability of Georgia's healthcare providers. As previously mentioned, we haven't been able to fully review this substitute yet, but we are ready to work with all interested parties, and we look forward to being at the table. Thanks.
Thank you. Josh Belinfante with RGR HCA.
Good afternoon, members of the committee. I represent Hospital Corporation of America, or HCA. We have 186 hospitals in the United States and in Great Britain. We have 5 still in Georgia, along with 6 ambulatory surgery centers. HCA is a tax-paying hospital. In the state of Georgia, that means that we have paid about $70 million, and that was before the acquisition of Satilla in Vidalia, Georgia. And we provide $178.3 million in charity and uncompensated care. I want to thank the committee, the chairman, and Chairman Watson for this bill. HCA's position is we think that Georgia would be best served if we got rid of CON altogether. We operate in states as diverse as California and Texas, where there is no CON regulation. And believe it or not, hospitals do just fine. But we think this bill is a step in the right direction. We want to thank both Senator Dolezal and Senator Watson for the amendments regarding the hospital authorities so that HCA hospitals can take advantage of the same provisions in the bill that were there. And we think this is a step in the right direction, and we will continue working with folks throughout, and also thanks to the Lieutenant Governor's office.
Mr. Tony West, Americans for Prosperity in Georgia.
Chairman Cowsert, members of the committee, my name is Tony West, and on behalf of Americans for Prosperity activists across the state, I'm here to speak in support of Senate Bill 162. We believe Georgia should move towards a patient-centered healthcare system that lowers costs, increases choices, and improves access for millions of Georgians. And we believe the reforms outlined in this bill would promote all of these important goals. CON costs Georgians dearly. Since 2010, approximately $700 million in healthcare investment has been denied. As of January 3rd of this year, another $269 million of investment of approved projects are stuck in appeals. An example of this occurred in Cartersville, Georgia, where a provider there applied to add 4 Level 2 neonatal ICU beds, or NICU beds. Bartow County is the largest in the state without a Level 2 NICU. And on March 24th, 2020, just as America began to grasp the severity of this new coronavirus, this NICU application was denied. The DCH commissioner overruled the decision, but competing providers appealed, and that appeal was stuck in litigation for years. If I'm not mistaken, the appeal was finally withdrawn recently, but not before Bartow had to go through a once-in-a-lifetime pandemic without a Level 2 NICU. This wasn't the only instance in the last few years of this. NICU beds planned for Savannah were also denied in 2019. Another example of con affecting women and children directly was a December 2021 denial for a freestanding birthing center in Augusta. The executive director of that birthing center couldn't be here today, but she wrote a letter of support for this bill, and it should be included in your committee folders. In 2022, the March of Dimes gave Georgia a grade of F for poor maternal and infant health, and the restrictions of con no doubt contributed to that rating. The true cost of con is unknown, but certainly greater than it would show on paper. Prohibitive application costs and the threat of competitor opposition preclude many providers from ever applying to offer services they otherwise would. I believe someone signed up to speak after me today can share about this deterrent effect from personal experience. This con system has contributed to the astronomical rising costs of healthcare Americans have experienced over the last 2 decades, or several decades, I should say, and has led to lower quality care and less access to care where patients are afforded fewer and fewer options. In 2018, under the Trump administration, the Department of Health and Human Services, Department of Treasury, and Department of Labor all issued a joint study covering a multitude of things, but included in it was this quote, "The evidence to date suggests that con laws are frequently costly barriers to entry for healthcare providers rather than successful tools for controlling costs or improving healthcare quality. And based on that evidence and their enforcement experience, the 2 federal antitrust agencies, the Federal Trade Commission and the Antitrust Division of the Justice Department, have long suggested that states should repeal their con laws." And it's worth noting that similar pronouncements also came out of the Obama administration before that. To conclude, I want to turn back to that denial of NICU beds in Cartersville. The appeals case came before presiding Judge Stephen Lewis Dillard of the Georgia Court of Appeals, and in it he wrote, quote, "One thing is for certain, Georgians don't benefit from a system that props up monopolies. And if the Con Act results in mothers and their babies being separated shortly after birth for no other reason than to preserve a healthcare provider's bottom line, then that system is fundamentally broken and it needs to be reimagined." Reimagining healthcare. We think that's what this bill could help contribute to do. The reimagining of a healthcare system where providers compete against each other for patients' business instead of competing for government's favor. Reimagining a system where providers are free to serve and patients have more options at a more affordable price. And that's why we support this bill. Thank you.
Thank you. Mr. Monty Veazey from the Georgia Alliance of Community Hospitals. Got 2 more, and then we're going to
Okay,
take action.
Mr. Chairman, thank you. And in lieu of time, too, I am Monty Veazey, president of the Georgia Alliance of Community Hospitals. We represent over 92 healthcare systems throughout the state, the smallest hospital in the state to the largest. We support certificate of need. However, we are willing to come to the table and have those discussions. Unfortunately, we just got this about 2 hours ago, and while we do want to highlight some issues in it, I voted for CON in 1979, and I've been defending it ever since. So I have a lot of experience with it, but I would like to thank you for allowing us and reemphasize we have a great interest in taking a seat at the table for these discussions. We've not been asked to, but we would be more than delighted to have those discussions. In lieu of time, I'd like to turn it right over to Kathy Palvino, our legal counsel, to address some issues.
Thank you, Mr. Chairman and members of the committee. As Mr. Veazey said, we would like to discuss this bill. We would like to, to be at the table to discuss the intent of it and the purpose of it. As it stands right now, we do have some concerns. There is, as has been said, this program will eliminate CON. In its place, there's going to be this alternative special health services license framework. That framework, as it stands today, it has no standards. It eliminates the reporting of quality data that was put in place in 2019 in House Bill 186. it completely deregulates certain services and facilities that were previously regulated. The list of those facilities is pretty significant. There would no longer be regulation for open heart surgery. There would no longer be regulation for cardiac caths or PCIs, for radiation therapy, for level 3 NICU. Services where quality has been an important factor. The CON law in those cases is the only law and regulations that set forth quality standards. What is the competency of a facility? How much volume will help assure quality of care? What is the proficiency of a interventional cardiologist? Are they board certified or not? All of those standards are contained in the CON law. All of those would be gone under Senate Bill 162 as currently written. So we are concerned that reporting goes away, quality standard goes away. We also would ask you to look at the definitions because the definitions have changed significantly from the CON law to this bill. As a result, there are loopholes. As we are reading the bill, and again, we just got it a couple of hours ago, while a special health care service license would be required for the conversion of a single specialty ASC to a multi-specialty ASC, there would not be any license required for the development of a new multi-specialty ASC. Those would be deregulated completely. Again, that may not have been what's intended, but we're reading the definition of healthcare facility, and it's defined to only include single specialty ambulatory surgery centers. So that's, again, we would like the opportunity to flag some of these issues that have caused concern. We would also ask you to consider, as you're hearing about CON and complaints about CON, the 2019 CON reforms have already resulted in change. The number of CON applications filed dropped by approximately 37% in the 3 years following the 2019 changes. However, a lot of the changes that were recommended to modernize the CON program under House Bill 186 in 2019 were not implemented and haven't been because obviously COVID-19 and the pandemic was the priority. So we would like to talk through what of those processes and procedures to make the CON law more modern and updated could take place. As I mentioned, there are, in terms of what is approved and what is not approved, a lot of these amendments and changes have made Georgia CON, there are a lot of exceptions and exemptions already. Over the past few years, going back 10 years, the approval rate for CONs is running at approximately 94%. That was 2022 to date. The number of CONs denied is very low. Even in circumstances where they're pointing to denials, for example, a lot of those denials result in approvals when they go through the process, when an entity or applicant can show they meet quality standards. So there is a role for CON for things like making sure you have a transport agreement if you're delivering babies out of a healthcare environment. Time is important. For a cardiac procedure, time is muscle. So making sure that entities trying to come in and offer services have in place safeguards to take care of patients, we believe that that's important, and we are concerned that this bill eliminates those types of safeguards.
Thank you.
I would also note that in the past 10 years, as mentioned, NICU services, there's been one application that was denied and remained denied for NICU services in 10 years. The only other case where an application was denied, the applicant refiled and corrected deficiencies in their application and was approved. So the law is not as onerous as it's been made out to be. There are places where it could be modernized. We agree, and we would like to be part of that process. Thank you.
Thank you. Chris Denson, if I could get you to hold it close. I will correct a couple things. I know you've seen Senate Bill 99 because you met with me for about 30 minutes on it 10 days ago, and Monty Veazey met the Lieutenant Governor this morning. So I know there may be some changes in 162, but it didn't change the verbiage of the Senate Bill 99 that went in it. Chris Denson, if you're here, now's your chance. Try to keep it quick. We're about to lose our quorum.
Yes, sir.
My name is Chris Denson. I'm the Director of Policy and Research for the Georgia Public Policy Foundation. We are a nonprofit, nonpartisan think tank located here in Georgia. We focus on economic policy as it relates to the state, including health care and the negative effect of Certificate of Need laws. I am here today to express our general support for Senate Bill 162 and commend Senator Watson for bringing it forward. Currently working on an economic study with Matt Mitchell of West Virginia University. He's one of the nation's foremost scholars on the economic impact of what Certificate of Need laws do on a national and state basis. And I will keep my remarks brief. But Matt has found so far that the majority of, while the existing academic research on the correlation between con laws and quality is inconclusive, the majority of academic research on CON has found it does not contain healthcare costs, it does not ensure adequate supply and access, including in rural areas, nor does it ensure that more charity care patients receive care. For many of you that are on this committee, you have heard the arguments for and against CON laws many times. You have heard that CON laws protect hospitals. They have to serve every patient that walks through their doors from having their profitable service lines poached by ambulatory surgery centers, also known as ASCs, and standalone imaging centers. They'll explain how this profit helps defray the cost of their uncompensated care. CON laws were never intended to cross-subsidize hospitals and the care they provide to indigent or charity care patients. CON laws were designed to keep healthcare costs down for consumers at a time when the federal government subsidized nearly every healthcare facility and service line investment in the country. And so, as you heard from Senator Watson earlier today, the focus of my remarks is going to be on this argument you often hear on the catastrophic effect that repeal or erosion of CON laws will have on safety net hospitals, particularly in rural areas. When I speak with my counterparts at state think tanks across the country, I can tell you no state has done more over the past decade to ensure the survival of rural hospitals than Georgia. This includes direct appropriations, numerous study committees, grants, increasing disproportionate share payments, and now this hospital-directed payment program that Senator Watson outlined earlier today. This program in particular will help ensure the survival of many of our rural hospital community providers. For all the economic reasons that I'm getting the signal to wrap up here, let me just touch it. Yes, sir. I'll touch base briefly.
You're about to kill the bill. If you support it, you might want to sit down.
Yes, sir. I support it. I'll sit down and appreciate your consideration.
Okay. Ms. Askins, you gave us, did you submit something to the committee? Okay. Okay. I'm going to give you about 30 seconds since you made the effort to come here because I've got a committee member that's leaving in about that long. I apologize that you got here so late. I called y'all in the order you signed up. You were the last one to get here.
I found out after I got in the room that I needed to sign in and had to go back out. So thank you for taking the time to hear me. I just wanted to briefly speak because I represent one of the blind spots, I think. I support Senate Bill 162 because the Certificate of Need deterred me from proceeding with trying to open my birthing center. I come from a long line of healthcare workers. My grandmother's a retired RN. My aunt was a certified nurse midwife who also delivered my first child. I am a former healthcare worker, and I've been on the administrative side of healthcare for years. So I have a lot of respect for healthcare workers and the need for hospitals to exist and what the role of the facility is. However, being inspired by the deliveries I got to attend to open a birthing center because of my love for birth work, mothers and infants, and safety, I wanted to provide safe and healthy alternatives and affordable alternatives for delivery. But I immediately ran into some issues. There's a lot here, and I can submit that if I need to. Just a few things I want to wrap up and say really quickly. One issue with mainly the hospital transfer agreement for birthing centers. if an emergent patient exists and needs to be delivered, I don't have to have a transfer agreement for them to be seen. It's illegal not to see my emergency patient in an operating room. Also, the hospital transfer agreement puts the mother and child right back where they were in the hospitals filled with sick patients, which we saw during COVID. Those are not sick events. Normal births are life events, and we don't need them at risk. And the other things is the hospitals get to have a direct incentive to pull the plug on these agreements, and they do often. So I'm asking for support of Senate Bill 162 so that
Thank you
those of
so
us
much.
who love birth work and mothers can provide safe, affordable alternative
Thank you for
solutions.
coming today. I apologize for rushing you there. All right, what's the pleasure of the committee on Senate Bill 99? There's a motion by Chairman Press, second by Chairman Dolezal. Any discussion or proposed amendments? 99, Senate Bill 99. Senator Dole, it is on. No, you seconded a motion for do pass on 99. Do you have a proposed amendment for it?
Yes, I believe, Mr. Chairman, make an amendment, as I believe is in everyone's folder.
It is.
Do I need to read it, or can I point to it?
You're going to need to just briefly
I'm going to
summarize
make
it.
a motion to amend Senate Bill 99 by striking through lines 23 through 25, and then striking through 7 on lines 26, replacing it with 6, striking through 8 on line 27, replacing it with 7, striking through 7 on line 29, replacing it with 6.
There's a second. All right, any discussion on the amendment? All right, any further discussion on the bill, Senate Bill 99 as amended? We're working off of the committee no, it's not a committee substitute. It's LC 339327 as amended will become a committee substitute. All right, all in favor, raise your hand. Got 7 yeas. All opposed, same sign. Got 3 noes. All right. 4 noes. 99. All right, that passes now. Is there any? Yes. Is there any pleasure? What's the pleasure of the committee on the committee substitute to SB 162? That's LC 339423S.
Mr. Chairman, I'd like to move that we table that until we get our next meeting where we can have a little time to study it.
All right, that motion would have precedence. Second by Senator Summers. All in favor of tabling the bill, raise your hand. 1, 2, 3, 4, 5. All opposed, same sign.
To table?
There's 5. It's a tie. I'll vote against tabling. Let's take action. It's before the committee. All right, there's a motion to pass and a second. Any proposed amendments to the committee sub of SB 162?
Number 4.
All right, Senator Albers, you're recognized.
There are 2 amendments in the folder. First one is AM 33, 2018. It is to amend substitute for SB 162 by striking lines 266, 268, then striking line 269, inserting its place F where it was G, and then on line 270 replacing H with G, and then by striking A through G in line 272 and inserting in place A through F. That's my first amendment, and I have another one afterwards. No, we're on 162 now.
Is there a second to the amendment? There's a second. Senator Kennedy, can you find, it's not a constitutional amendment, it's Senate Bill 162. Senator Kennedy, let me catch you up to speed. There is a,
We just did this.
You got
one.
it?
I haven't done
all
2020.
right, so it eliminates a requirement to have what's now referred to as a medical services license for capital improvements, regardless of the amount. And then it eliminates the requirement that you be a community hospital, not community hospital, authority to qualify for the rural healthcare exemption.
And I have a second amendment here.
I might have already spoken as to that. Well, let's act on your first one. That was seconded. All in favor of that amendment, which mirrors Senator Dolezal's amendment on SB 99, raise your hand. Any Any opposed to that, same sign. Cindy, you got that? We got.
I know exactly where we're at here, Chairman. You doing both of them at the same time?
No, we don't. We do one at a time. We just did the first one. Senator
2018.
Albers,
Yes.
go ahead with that passed.
Second Amendment, AM 33, 2020, it's simply to amend the substitute of SB 162 by striking of $10 million or less from line 483.
There's a second by Senator Dolezal. Any discussion as to that amendment? Senator, all right, all in favor, raise your hand. What you got, Cindy?
Just the amendment.
You through counting? Yes. All opposed, same sign. 4 against. That amendment passes. All right, so now we have before the committee substitute to SB 162 as amended by the 2 amendments presented by Senator Albers. We're working off of LC 339423S. All in favor? Committee sub SB 162 as amended, raise your hand, please. 1, 2, 3, 4.
5, 4.
All opposed, same sign. I'm going to let the full committee decide. I'll pass that out of committee. It was 5-5 tie, right?
You got 6.
We had 6. He voted yes.
I voted yes.
Okay.
Much as I didn't like shoving it that fast.
Right.
You had 6 no's. You had 6 yeses too.
Thought I had 6 yeses.
You had 6 no's. How many yeses?
It passed.
All right,
Doesn't matter.
let's count again. All in favor, raise your hand. Ken's got his hand up. It's just all Ken.
6. You got 6. You got it.
There's 6 in favor. Now, raise again. All opposed. 1, 2, 3, 4, 5, 6 opposed. Once again, I'll break the tie and let this go to the floor for a vote. We'll let the body decide on it, assuming that the rules chairman lets it go to the floor. That is all the business on our agenda for this evening. Tomorrow night is the committee dinner, 6:30, 57th Fighter Group, and on Thursday, we will have discussion of the problem gaming on the constitutional amendment and the Senate Bill 172. See y'all there.